Okay, good morning everyone. My name is Hamed Ekhtiari. Delighted to be here, and it's just a fantastic day in the World Congress of Psychiatry here in Prague. First of all, you have my slides in the QR code. So if you bring your phone and see if the QR code is working. So you have the slides in the PowerPoint version, and it is open, so you can just change it or use it in a way that you want in the future. So is it working? Can you see so it is in the Dropbox. Okay, so you can have the slides. I will provide the QR code at the end of the presentation as well. So you will have access to the slides. So please feel free to use the slides in any way that you think that it's going to be helpful for your work. And then before starting the workshop, how many of you are acting as addiction psychiatrists? Okay, so like half of the people in the room. How many of you in the room are residents of psychiatry? Okay, the other half. Sounds good. Anybody who is an addiction psychiatry fellow who is doing their fellowship? Okay, good. Now we have a little bit of sense about who is in the room. So let's just start with some warm-up questions, and then we'll go from there. So what are the specifiers that we have for substance use disorder in DSM-5? A, B, C, D, E, or F? The specifiers that we have for substance use disorder in DSM-5. Who's going to answer? Who's going for A? E? Okay, what else? Okay, so let's further discuss. And then, what are the medications in this list that they are associated with higher risk of hospitalization and death in people with amphetamine use disorder? A? Who is going for B? B? And then D? Okay, so let's think about, these are the things that we are going to address and discuss further today. And we have a patient with amphetamine use disorder who uses meth mainly because to be able to start their day. What would be the medication that you want to try for them to address that specific need? Bupropion, mirtazapine, naltrexone, bupropion augmented with aripiprazole, and mixed amphetamine salt. A, depending on the case, like any clinical case scenario, that is always true, right? But A or E, D. Okay, good. So we'll further discuss those sort of topics during the workshop with me and also other speakers. So I'm trained to be both neuroscientist and addiction psychiatrist. So I'm coming from an MD, PhD background and trying to bring neuroscience to addiction medicine, addiction psychiatry. And when we talk about addiction neuroscience, you usually have a graph like this, right? These kind of connections and how these different areas in the brain are interacting. Have you ever used these graphs in your clinical practice? I mean, anything that you say, okay, I'm going to do this in my clinical practice because of that connection in the brain. Right? I mean, it is not most of the time the case that we say, okay, let me just find that specific figure from Nora Volkov paper and find if basolateral amygdala is connected to nucleus accumbens or not, and based on that deciding whether I'm going to prescribe that specific medication or not. Right? So this is not the reality in the practice. These figures provide us with what we call circuit level understanding, which is very dear and close to our heart as neuroscientists, so we really like that, but it is not actually used in the clinical practice of addiction psychiatry. If we want to use circuit level understanding, you need to use a specific group of therapeutics that we call circuit level therapeutics, okay? And this is a new generation of treatments that we are developing with different kind of TMS, electrical stimulation, deep brain stimulation, that we target those circuits, right? So if you are already using TMS, who is using TMS in their clinical practice right now? Okay, so those who have started to use TMS in their clinical practice, they need to start thinking about how to use these sort of circuit understanding to be able to optimize the interventions. But if you are not doing that, that might not be the case. My lab is mainly focused to develop those sort of circuit-based therapeutics. So we try to find what is the best circuit in the brain to target to be able to have access, for example, to nucleus accumbens, to amygdala, to change the way that people experience craving, and even using robots to be able to find those sort of circuits. But this is specifically not the target for our discussion today in terms of discussing about circuit level therapeutics. Those who are interested in circuit level therapeutics, we have a specific line of workshops and education materials for those who are interested in that specific line.